for today is Dr. Kathy Mwendo. So Dr. Kathy Mwendo also did her undergraduate and postgraduate here at the University of Nairobi, and she did her fellowship in pediatric oncology at the Mulago National Hospital and at the Baylor College of Medicine. She's enthusiastic about improving the outcomes of children with blood and cancer disorders in Kenya through novel interventions that are sustainable in resource-limited settings. Dr. Mwendo's professional interests focus on low-cost intervention to aid early recognition of childhood malignancy, such as improving community awareness and improving healthcare linkages to the appropriate service in order to receive prompt and timely cancer care to optimize good outcomes. Her research interests include cytogenetic changes and molecular basis of acute leukemia and lymphomas in African children, and the relationship between infections, most overall infections, and malignancies in African children. So those are our two speakers for today. They are experts in this field with the vast knowledge in pediatric hematology and oncology. So I know we'll have a great wealth of benefit of knowledge by just listening to them. And so we are going to discuss pediatric acute leukemias and pediatric lymphomas. And we'll begin with Dr. Irene Nzamu, who will do the presentation on acute leukemias, and then we'll go on to Dr. Catherine Mwendo, who will do a presentation on lymphomas. So I'd like to request you to put your any questions, any concerns you may have on the chat box, and we'll capture them. And at the end of the sessions, we'll have a question and answer session. So thank you and welcome.
Thank you very much, Dr. Wata, for the kind introduction. This is Dr. Catherine Mwendo. I just want to correct something. I'll be the one taking us through the pediatric leukemias, and then Dr. Nzamu will take us through the pediatric lymphomas. So just, I want to share the screen. Are you able to see my screen?
Yes, we can see the screen, Dr. Kathy. Thank you.
All right, thank you very much. So thank you very much for inviting me to give this talk. So we'll be looking at an overview of childhood leukemias today. And the reason for giving this talk today, again, is just to create awareness for childhood cancer and advocate for affordable and quality care. I don't know if we are aware, but September is the Childhood Cancer Awareness Month. This is a month that's recognized by various childhood cancer organizations all around the world. And so as we begin September in the next coming few days, we want to generally have that theme of creating awareness of childhood cancer. So the outline of our talk today, we'll have a brief introduction about leukemia, look at the epidemiology globally, and also look at the local data. Etiology, look at the potential causes of the leukemia. Then we'll look at the clinical presentation, how to make a diagnosis, and conclude on treatment and prognosis. As we know, Leukemia is a cancer of the blood and blood-forming organs, resulting in the formation of increased number of immature or abnormal leukocytes. So basically, it's a malignant disease of the bone marrow in which you have those early lymphoid or early myeloid precursors proliferating, and then they replace the normal hematopoietic cells of the marrow. There are three main types of leukemia in childhood. The first one is the acute lymphoblastic leukemia, what we call ALL. It's the commonest, accounts for about 75 to 80% of cases. Followed by acute myeloid leukemia, AML, which constitutes about 20% of cases. And then we see chronic myeloid leukemia in 10% of cases. I put up this other type of leukemia called juvenile myelomonocytic leukemia, JMML. It is quite rare, but it occurs in infancy and early childhood, but in about 2% of cases. In my experience, I've seen just 1 or 2 cases when I was doing my fellowship. Globally, according to the SEER cancer statistics, it stands for Surveillance, Epidemiology, and End Results. In the year 2009 to 2012, they looked at patients aged 0 to 14 years, and it showed that approximately 400,000 children are diagnosed with cancer each year. The commonest cause of cancer was noted to be leukemia, which is highlighted in blue in the pie chart. So the childhood leukemias represented the most common pediatric malignancy, accounting for approximately 31%. Then it was followed by CNS or brain tumors in orange at 26%, and then lymphomas at 10% in gray. So if you combine the leukemias and lymphomas, you find that these hematological tumors actually are the commonest type of cancers in children. When you look at, this is also another illustration of the various cancers in children. And as you can see, highlighted in maroon, children less than 15 years of age, acute lymphoblastic leukemia is the commonest at 25%. That's the incidence. It's less commoner in now the older children and the adolescent at 15 to 19 years, it's 7.5%. AML incidence is 5%, but then again, at 15 to 19 years, it remains around the same, 4.3%. AML has 2 peak age groups. You have in the early infancy from 0 to 4 years, and there's another peak instance of AML in the older children from adolescents around 14 years to 16 years. Then thereafter that you get to see the CNS disease, but that's more the brain tumors. So what is the data we have locally? Most of the data we have is retrospective. It is hospital-based. Unfortunately, we do not have like a form of a national cancer registry where you can easily access this information. So we are heavily relying on what is published. So what I got is retrospective data from the two national hospitals in Kenya. So one from Kenyatta National Hospital and the other one from the Moi Teaching Referral Hospital. This retrospective data is over a 10-year period. So in KNH, this paper was published in 2020. It speaks of a prevalence of 30.6% of leukemia. The males are affected more than the females, with a peak age range of about 0 to 4 years. In Western Kenya, a study that was done and published in 2012 showed a leukemia prevalence of about 15%, with a median age at diagnosis of about 8 years. So what are the causes? What causes leukemia in children? Is it just bad luck, or is it we do not know? So there has been studies that have been done, and they are still ongoing. So we have some hints from the current research, and I broke them down into three. So there is evidence that they could be linked to what happens in utero. So when children are in the womb, there could be some events that happen as this child is forming and growing. So those are the prenatal, pre-leukemic events. And what informs this is there's been some evidence of genetic mutations being picked up in children who later go on and develop leukemia later on in life. So there's evidence that in acute lymphoblastic leukemia, those that have low hypodiploid ALL, meaning they have less chromosomes, 30 to 39 chromosomes in the leukemia cell, is a Liu-Fraumeni syndrome disease. Because what they found is about 50% of cases that have this low hypodiploid ALL have the TP53 germline mutation. TP53 gene is a tumor suppressor gene. And what it does is it regulates cell division by controlling the proliferation of cells. So if you have a mutation in a tumor suppressor gene, then you would find that there will be uncontrolled cell division and proliferation. And germline mutations basically are mutations that are inheritable. They pass through to the offspring through generations. KMT2A rearrangement, or what we call MLL, which is a mixed lineage leukemia mutations, also have been noted to arise in utero. So you find that infants actually less than 12 months who have leukemia, tend to have these mixed lineage leukemia mutations. And so it is thought that actually these mutations arise in utero and tend to now manifest when the child is born and much later on in life. Concordance rates between identical twins is actually 100% for leukemia occurring in infants less than 12 months old. So concordance is primarily due to that prenatal acquisition of the genetic mutations, so the chromosomal translocations or even any other genetic lesions. So it's acquired prenatally, and then it is transferred of these pre-leukemic cells to the other twin. So when you have identical twins and one twin unfortunately develops leukemia early on, like let's say before 1 year, then the chances of then developing leukemia in the other twin is 100%. If the leukemia manifests when the child is less than 12 months old, that's what we call the concordance rates. But if they develop leukemia later on after infancy, then the concordance rates also go down. It goes down to 10 to 15%. It's still higher than the general population, but it's not automatically, like we don't assume that the other twin will get the leukemia. So the second hint is the cancer predisposition syndrome. As the name says, these are syndromes that predispose one to cancer. So I've already talked about the Liu-Fraumeni syndrome, which is a germline TP53 mutation. Down syndrome, children with Down syndrome have a much higher risk of developing leukemia than the general population. They tend to have a higher risk, almost 300-fold, of developing AML from 0 to 4 years of age. So their risk is about 300-fold. But thereafter, after 4 years, then the risk of developing ALL becomes then higher. Bloom syndrome and the rest, Fanconi, dyskeratosis congenita, and myelodysplastic syndrome. Also, these are syndromes that predispose one to have cancer much later on in life, just because of the genetic mutations of that syndrome. So it has been shown that 4 to 5% of pediatric leukemias have germline mutations in known cancer predisposing genes. There is something else called therapy-related leukemia or secondary leukemia. This is leukemia that develops probably after exposure to agents such as drugs, chemotherapeutic agents, or even radiation. So it is known that exposure to alkylating agents, examples are like cyclophosphamide or topoisomerase 2 inhibitors, examples etoposide, is linked to development of a secondary leukemia much later on in life. So you might find a child who probably was treated for, let's say, a solid tumor, maybe Wilms tumor, went into remission, has been on follow-up and doing well. And then much later, years later, 3 to 5 years later, then the child develops leukemia. So that is a therapy-related leukemia or a secondary leukemia. So this is a schematic diagram just to illustrate what I've been mentioning in the previous slide. And I just put one that shows the normal B cell development and how leukemogenesis occurs. So in the top row, you see the normal B cell development. So the initial B lymphocyte development occurs in the bone marrow. So you have a hematopoietic stem cell. The hematopoietic stem cell is a pluripotent cell. So it can differentiate into any cell line that is required. So in this situation, it would differentiate into a multipotent progenitor cell, then a common lymphoid progenitor cell. So it will commit itself to the normal B cell development. So what happens is, now in the bottom row, the first step of leukemogenesis occurs in utero. So from when the hematopoietic stem cell commits to the lymphoid lineage, there could be an initial event that occurs there. So there might be a chromosomal translocation or any other genetic lesion that would generate a covert pre-leukemic clone. So in this situation, the initial event is a chromosomal translocation, such as a PAX5 ETV6 translocation, and it sort of generates a covert pre-leukemic clone. And that cell still commits itself to be a B lymphocyte. However, the second event occurs. This second step is usually acquired postnatally. So it could be a postnatal acquisition of a secondary genetic change. It could be de novo, like sporadic. It could be due to exposure to something that just changes the gene, such as an infection or an exposure to an agent, a drug, or a toxin. And that now drives that covert pre-leukemic clone to an overt leukemia. So you find that what we do not know is what's that second hit? What actually causes this pre-leukemic clone to actually now become a leukemic clone? Because what we know is only about 1% of children born with a pre-leukemic clone actually progress to develop leukemia. Not every child who has a pre-leukemic clone will actually get leukemia in their lifetime. So I guess that is where the bad luck comes in. So in the clinical presentation, leukemia is a heterogeneous disease with variable clinical presentation. So there was a study that was done in about over 3,000 children. In this analysis, they were looking at the clinical presentation of childhood leukemia, and it was a systematic review and a meta-analysis. So looking at these children, what was present in majority of the children, more than 50% of the children in increased frequency was a hepatomegaly of 64%, followed by splenomegaly, then pallor, fever, and bruising. What was present in a third of the children, recurrent infections, followed by fatigue, limb pain, bruising, and then lymphadenopathy. So as you can see, the clinical presentation can be variable. Actually, they talked about 6% of children in this particular study were asymptomatic on diagnosis. So you can find a child who's just coming in for routine checkup. A blood count is done, and you sort of see some abnormal cells, abnormal white blood cell counts that lead you to further investigate, and you get the diagnosis of leukemia. As we talked about the definition of leukemia, you have proliferation of those early precursors that replace the normal hematopoietic cells. So because of that, of those abnormal cells, there will be inhibition of or rather there'll be abnormal bone marrow function. So there'll be inhibition of red blood cell production, and they would present with pallor and fatigue, and probably there'll be reduced play in the younger children, reduced concentration at school for the older children, just because of the anemia. They would have inhibition of platelet production by the bone marrow, and that's where you see the bruising. There is unexplained bruising. There was no trauma, there was no surgery, just a spontaneous bruising and bleeding. Inhibition of white blood cells, which really are used for immunity. Then you would find these recurrent infections occurring and fever. And it's unexplained because probably this child has been given all antibiotics, exposed to a lot of antibiotics, but yet the fever persists. So that is what they found. In the limping, we know it's usually due to the expansion of the bone cavity by the leukemia cells. So unfortunately in children, we do not have preventive strategies like screening for leukemia. There's really no guideline or no evidence to say that we should be doing a blood count in children every so often as a routine check. So what we heavily rely on is early warning signs. What are these signs that when you see in a child, then they make you suspicious for a cancer or a leukemia, and so you want to investigate further? So number one, pallor, bruising or bleeding, and general bone pain. This is not something that is common in a normal child. So once you see that, you'll be able to have a high risk of suspicion. Lumps or swelling, especially if painless or without fever. So we're talking about lymph nodes. Large lymph nodes that are progressively growing or that are persistent for a long time, you need to investigate for that. Unexplained weight loss, fever, shortness of breath, or night sweats, what we call the B symptoms, are also should raise a suspicion. Eye changes, things like the white pupil, a new onset squint, visual loss, bruising or swelling around the eyes is very suspicious. You should be thinking of, probably an eye, a retinoblastoma or any other cancer, and needs further workup. Abdominal swelling, usually for the children who have Wilms tumor or any other abdominal tumor, sometimes it's just coincidental. Maybe they're taking a shower and the parent actually feels a mass, and that's how they come and present to the hospital. Headaches, vomiting could suggest a brain tumor. Limb or bone pain or swelling without trauma or even without signs of infection should raise an alarm. Fatigue, lethargy, or changes in behavior such as being withdrawn, again, that's not very usual for children, so you need to work them up. Dizziness, loss of balance, or coordination can also be suspicious for a brain tumor. So when should you consider the diagnosis of leukemia? You should consider diagnosis of leukemia when there is a combination of unexplained adenopathy, so lymphadenopathy, or marked hepatosplenomegaly, as we've seen in that meta-analysis. Hepatomegaly and splenomegaly were what was actually in increased frequency that in those children who presented with leukemia. If they have bone pain, bleeding symptoms, or pallor, and if 2 or more cell lines are abnormal in a blood count. So if you have white blood cells that are unusually high and the other cell line is down, so whether it's the hemoglobin or the platelets tend to be very sensitive to in leukemia. So I'd be very suspicious of a leukemia if those platelets are down compared to if the platelets are normal. So if you have all the cell lines that are down, that is a pancytopenia. You could have two cell lines down, that's a bicytopenia. Or if the white blood cells is unusually high and one of the cell lines is down. So how do you make a diagnosis? Leukemia is a bone marrow diagnosis. You need to take a bone marrow aspirate and look at it under the microscope. So in acute lymphoblastic leukemia, according to the FAB classification, that's the French, American, British classification, it sort of separates ALL into 3 categories. There's the L1, L2, and L3. And this is using just the morphology, what you see with the naked eye under the microscope. So when the bone marrow aspirate when the bone marrow aspirate procedure is done, so that aspirate is smeared on a slide, it is subjected to a special stain, and then you look at it under the microscope. So what you see, that is what we call the morphology. So L1, L1 blasts are seen mostly in about 85% of cases. As you can see in this picture, these cells that you see right there in the middle, they are large. They look abnormal. So that's what we call homogeneous. There's no one that looks different from the other. And the nucleus is regular, so it looks nice and round. Chromatin is homogeneous. Again, it just feels like the same. Hardly has any cytoplasm. So that is an L1 ALL. L2 looks a bit different now. So this nucleus is irregular. It is heterogeneous, like it doesn't look the same. The cytoplasm, the chromatin doesn't feel the same, and it has nucleoli. So that is an L2 ALL. L3 is a bit different, and you can see it has this whitish appearance in it. Those are cytoplasmic vacuolations. They look like bubbles. And that speaks over more of a Burkitt's type of leukemia. I'll go through the immunophenotype in the subsequent slides. So in AML AML and LL totally different. So in AML, there are actually 8 categories using the FAB classification. So that is from M0 to M7. Again, the blasts of AML look a bit different from ALL. They are larger. Usually they're larger. The nucleus is bigger. They have more cytoplasm. And now it will depend on how the granules look. One of the distinct characteristics in AML compared to ALL is the presence of R rods. R rods look like rods, maybe needle-like structures within the cytoplasm, and they are quite distinct of myeloid lineage compared to a lymphoid lineage. So that's the first thing. But not all myeloid cells have the hour rods. So sometimes it might be difficult to differentiate this blast, this myeloid blast from a lymphoid blast. And that is where immunophenotyping comes in. And I shall talk about that in the subsequent slides. I just want to highlight to you the M3 morphology. So this is a different type of myeloid cell. Even in its morphology, how it appears, it looks a bit different from the others, the M0, M1, 2, 4, 5, and 6, and 7. It tends to have a folded nucleus. It has quite large cells with a lot of cytoplasm, and the hour rods are also very distinct. And the nucleus looks folded, or rather like a butterfly. And this type of leukemia, the M3, they tend to bleed a lot. So the first suspicion is usually clinical. The child who was previously well just comes in bleeding. A bleeding cannot be controlled. And then if you look under the microscope after doing a bone marrow, you see this, then it raises a suspicion of an M3 AML. M7 AML, mostly we see it in children with Down syndrome, and it tends to have a good prognosis in the children with Down syndrome. And it's called the acute megakaryocytic leukemia. So as I was speaking about the diagnosis, so this is a standard diagnostic approach. History and physical examination is very important, just to tease out what is characteristic of the, whether it looks like a leukemia or not. Then the simple labs are important. Blood counts would actually can give you almost a diagnosis, or rather a suspicion to further do more workup. Electrolytes to check on the renal status and the liver status. Imaging is important, especially at chest X-ray, because you want to rule out a mediastinal mass and assess safety for anesthesia. Most of our children, we perform these investigations under anesthesia because they're young, they're not cooperative. So you want to see whether it is safe to go ahead and sedate this child to do a procedure. Now, those are the simple labs. So the complex labs are now the bone marrow aspirate and biopsy. It's important to do both so that they can correlate. Sometimes you might actually not get an answer just with a bone marrow aspirate. And these are subjected to routine and special stains. So there are special stains for whatever leukemia you're suspecting. If it's a myeloid leukemia, there are special stains for that. Immunophenotyping by flow cytometry now. This is, you take your bone marrow aspirate and subject it to immunophenotyping. And I'll talk more about that. Other tests you can do to that bone marrow aspirate is cytogenetics. And lastly, a lumbar puncture is important for staging or for assigning a risk for these patients. So the three essential steps is to look at the morphology of the blasts. Usually cannot differentiate myeloid from lymphoid and most subtypes of myeloid. And for sure, it cannot define whether it's a T cell lineage or a B cell lineage. So that's when you need the immunophenotype. So that would define the T cell from the B cell from the myeloid lineage. Cytogenetics gives you data for prognosis and actually a clear definition of the myeloid subgroups. So what defines the immunophenotype? These are normal cell surface proteins, mostly identify cells to a particular lineage or stage of maturation. So in the T lymphocytes, they express the CD2, 3, 5, and 7. These are the single digits, if that's how you'd remember. In the B lymphocytes, they are more of the teenagers or the older adults in a way, if you'd like to remember that way. So the B lymphocytes would express the CD10, CD19, CD20, 22, 24, and the CD79. So CD is just a cluster of differentiation. In the myeloid cells, mostly is CD13 and CD33. And there could be others, but at least you need to see that it is expressing the CD13 and 33 to make it a myeloid lineage. So treatment, so how do you go about treating children with leukemia? First, you have to assign a risk to this child. So risk stratification is a process of grouping patients by similarity of perceived prognosis for the purposes of defining a treatment group. So these children are not all treated the same. And this risk stratification is mostly done for acute lymphoblastic leukemia patients. So you want to stratify them. Are they standard risk or high risk? And what are these parameters we look at? There are two we look at upfront because we have them with us. So the age of the child and the white blood cell count upon diagnosis. So the age of the child, if you are less than 1 year or more than 10 years, it puts you in a high risk category. If you're between the 1 year and 9.9999 years, then you are in a standard risk category. For the white cell counts, the cutoff is 50,000 cells per microliter. So if you are less than 50, then you're standard risk. If you're more than 50, then you are high risk. So you look at both of them. So if the age in itself, maybe you're 10 years and your white cell counts are just 8, you're still high risk because of the age. So it's either or. If the white counts are more than 50, but your age is between the 1 and 9, you still remain a high risk and you'll be assigned a high risk treatment group. CNS status comes much later. Most of this time, the children are sick. So you will go ahead and stabilize first and then do your lumbar puncture procedure, take the sample and take it for analysis. So the CNS status tends to come much later, a week later or so. And that, if the age and white cell count were putting you in the standard risk, but then the CSF analysis comes back abnormal, it then upstages you to a high risk category, and therefore you get more chemo or more treatment. The immunophenotype, if you have the facility to do flow cytometry, for the acute lymphoblastic leukemia, the T cell are a high risk category compared to the B cell. Cytogenetics, also, there are plenty of them. There are those which are favorable cytogenetics, and then there are unfavorable cytogenetics. And lastly, once we treat these children with ALL at induction, which lasts for 4 weeks, then you want to check again the bone marrow status and look for the remission status. So if you are in a facility where you're doing the immunophenotyping, then you look at the minimum residual disease, like what disease is left that even the eye cannot see. If you're not in such a facility, then you just do a morphology and talk about morphological remission, which are less than 5 blasts per high power field. So why do we assign risk? So that we can give risk adapted treatment. So the principles of that, it means you want to intensify therapy to improve the outcomes for those with high risk disease. Then you also want to de-escalate therapy to reduce the toxicities for those who do not have high risk disease. And of course, precision medicine for targetable lesions. An example of this is like the children who might have BCR-ABL positive mutation in ALL. Then you want to target that mutation by giving TKIs, tyrosine kinase inhibitors, to target that particular mutation in addition to the other chemotherapy. So the treatment of acute lymphoblastic leukemia, the common approaches is we give induction, usually lasts about 4 weeks, followed by consolidation, which lasts for about 6 to 8 weeks, followed by interim maintenance for about 8 weeks, delayed intensification for 8 weeks, and then maintenance would depend 18 to 24 months, with or without cranial radiotherapy, depending on the CNS status of this child. So the total duration of therapy is approximately 2 years for ALL. In AML, it's a shorter duration of treatment, but very intense. So they have about 2 months of induction and then 2 months of consolidation. So total duration of treatment is approximately 4 to 6 months. And we say that because you have to wait for the child to recover from the chemotherapy before they go on to the next step. So there might be a delay along the way as we wait for the counts to recover. So the role of radiotherapy in AML usually is very limited, and it's only limited to the life-threatening conditions such as chloromas or spinal cord compression. So generally, cranial radiotherapy is not required to control CNS disease in AML. So what is the role of bone marrow transplant? Usually, we do not even advocate for a bone marrow transplant upfront. We want to do a trial of a treatment. But however, there are certain things, if you have it beforehand, they would put you, they would give you more information whether this child actually needs to just be prepared to go for transplant or not. And those are the molecular studies. So children with adverse cytogenetics, such as MLL rearrangements, other genetic mutations such as monosomy 5, monosomy 7, those are children who, these are children with AML that you know you will, for them to just get a chance of cure, they need to undergo the hematopoietic stem cell transplant. Other roles for bone marrow transplant is children who have relapsed leukemia. These are children who relapse quite early in the treatment, meaning they're still undergoing treatment. At one point in their course of treatment, they went into remission, and then the disease is back. Compared to those who have late relapse, meaning you have treated for those 2 years, you've been following up for maybe a year or so, and then they relapse. Then maybe there is a role for trial of the chemotherapy again before sending them for transplant. Refractory leukemia is leukemia that does not respond to treatment. So at no point you get remission. So those are children who you want to prepare for bone marrow transplant. And those who have therapy-related leukemia, as I mentioned earlier. Matched sibling donors are most preferable. Other donors could be matched unrelated donors or haploid donors. Haploid donors are from the parents because they are half. Their genetic material is, the child contains half of their genetic material. So the sites of the stem cell harvest could either be cord blood. So there are areas where they harvest cord blood and store that. Or it could be from peripheral blood or from the bone marrow. So as much as, yes, we are treating these children for leukemia, we also have to remember that there are side effects to this treatment. These effects of the therapy could be either short-term or long-term. And for the short-term, we get to see them on a day-to-day basis as we are treating these children. And mostly it involves the skin, the hair, and the gut. So as soon as they start getting chemotherapy, we see that the hair falls off, the skin changes color, the nails change, they tend to get nausea, vomiting, and even appetite changes, and oral sores. They get myelosuppressed, so they easily get infections, easy bruising and bleeding, and anemia. So these are things we anticipate and we support. We inform the parents and we support these children because these are things we are anticipating that would happen. They also get constipation or diarrhea. Chemo brain is basically forgetfulness. They're not able to concentrate for long. They have fatigue and even mood changes. We see a lot of mood changes, especially children who are on long time steroids for a long time. Long term, we are talking a period of even 5 years, 10 years. They could get these long-term effects. So it's a matter of follow-up as you check these particular organs. So children exposed to anthracycline such as doxorubicin could have issues with their heart. in future, they can get cardiotoxicity, lung fibrosis, or chronic lung disease, children exposed to bleomycin. For the brain, it affects the IQ, cognition, and speech, especially those who are exposed to radiation. Kidney, they can get nephropathy, those who are exposed to drugs that affect the kidney, such as the alkylating agents. Bone and joints, you have osteoporosis if you have been on steroids for a long time. Infertility with alkylating agents or radiation, and even secondary malignancies. So these are things, even as we are giving a diagnostic talk to the parents, we have to bring it up that yes, we are treating because we want to control the disease, to give a chance of cure, but at the same time, there are side effects. So what is the prognosis? Looking at the pediatric acute lymphoblastic leukemia, it's actually a success story. In the past, in the 1960s, 70s, it was a death sentence. They would die, almost 3/4 of them. But somehow along the way, the outcomes have improved. So incredible strides in curing childhood leukemia has been seen, especially in developed countries. The major reasons that have attributed to this is risk stratified treatment. As we said, we intensify treatment for those with high risk and de-escalate treatment for those with low risk. Targeted therapy, treatment of sanctuary sites. So the CNS was recognized as a sanctuary site that needed special prophylaxis and treatment. And this includes the intrathecal treatment and cranial radiation. And most importantly, improved supportive care. This is the fluids, the fluid support, blood transfusion, platelets treatment, and use of antibiotics. So as it stands right now in the developed countries, the overall survival for a child with ALL is about 95%, the 5-year overall survival. So what is our outcomes in Kenya? We find from the studies that have been done, there was one that was done, they looked at 136 children with ALL between 2010 to 2016. The mortality for those children was 30%. Those who went on to have progressive and relapsed disease was 26%, with an event-free survival of 20%. 171 children diagnosed with ALL between 2001 and 2010. The case fatality rate was 64%. Relapse rate was half of that, 47%. Those going into remission were 23%. So as you can see from these statistics, our mortality rate is very high. And some of the attributable factors are lack of awareness and information on childhood cancer, which we are trying to do to address now by increasing awareness and information. Late diagnosis, so they come in with advanced disease, obstacles to accessing care, delayed or wrong diagnosis, the weak health infrastructure, lack of access to trained healthcare personnel, lack of access to quality cost-effective drugs, abandonment of treatment, and death from treatment mortality. Looking at the outcomes of pediatric AML, this is an AML BFM study. AML outcomes are a bit inferior compared to ALL. The 3-year overall survival is about 82%, and this is in developed countries. If you risk stratify them according to the cytogenetics, then you find those who have standard risk have a better outcome at 90% compared to those who have high risk at 72%. For us, in the last bullet, there was an AML study done in Western Kenya where they looked at 55 children diagnosed with AML between 2010 and 2018. Only 33% achieved complete remission. 56% of those children relapsed, and early death rate was 46%, with a 2-year event-free survival of 4% and a 2-year overall survival of 7%. So really, we are not doing very well as compared to the West. So I think with that, I will conclude. And I believe we shall take questions and comments at the end. Thank you.
Thank you very much, Dr. Mwendo. That was a very clear, concise, and fantastic presentation. I think all of us here in the audience now have a good grasp of leukemias in childhood. So thank you very much for that presentation. Kindly put your questions and comments on the chat box, then we'll pick them up at the end. So next, I'd like to invite Dr. Irene Zamu, who will take us through childhood lymphomas. So the floor is yours, Dr. Zamu.
Thank you, Dr. Wata, and thank you, Dr. Mwendo. We've had an amazing 1 hour. We chose to spend a lot of time on the leukemias because really that is the commonest cancer that we see in children, and it is worth it, and it is something that we can make a difference in the outcomes. The next few minutes, we'll just look at lymphomas in children. Can you see my screen?
Yes, we can, Dr. Nzamu, go ahead. We can see your screen, Doc. You can go ahead.
Okay, thank you, Dr. Wata. So we'll quickly look at the lymphomas in children, and we'll just look at the lymphadenopathy in children. Then we shall quickly look at non-Hodgkin lymphoma and Hodgkin lymphomas and a summary, because these are also important hematological malignancies in children. And the thing that probably bothers most of us a lot is when we come across a child who has lymph nodes that are swollen, especially around the neck. Most of us who are parents, we come across children and you're seeing these swellings all over the neck and you're wondering whether it is cancer, whether you should do something about it. And when we talk about lymphomas, we need to note that when we see a child presenting with lymphadenopathy, our biggest concern is, are they benign or are they malignant? Let us note from this data shown here that infection is by far the commonest cause of swollen lymph nodes in children. And you can see on top of this diagram that the biggest chunk is actually the reactive hyperplasias and a lot of infections. So when we talk about malignancies, it really comes a bit lower. Let us also take note that in children, 40% of them will have lymphadenopathy, which is normal, and 60% will be in sick children. Again, we are insisting on this message during this time as we raise awareness for childhood cancer. Please note that for children below 2 years of age, you can imagine the occipital nodes, the ones that come at the back of the head, 68% will be normal. And in children below 2 years, about 75% will have the lymph nodes around the neck. So we do not need to panic, especially when we see small nodes. Look at the age group between 2 to 12 years in the middle row. You notice that 100% of children, school-going age, little ones, are going to have those small lymph nodes around the neck. But please take note of the abnormal locations. So occipital, cervical, axillary, those ones can be normal in these percentages. But if you see lymph nodes in the posterior auricular area, around behind the ears, around the popliteal area, the back of the knee, epitrochlea, in the mediastinum, abdomen, and especially this one in the supraclavicular area, we need to be very concerned. So as we look at lymphadenopathy again, there are so many tests we can do because we are saying there are many causes of lymphadenopathy in children, not just lymphoma. So the most important two are the CBC and the chest X-ray, because these ones will tell you there's an abnormality in the blood count, which is your hemogram. And if your chest X-ray is having any abnormality or any masses, you start thinking of lymphomas. And then you look at the chemistries, the liver, we are looking for signs of infection with these CRPs, LDH, uric acid, we are looking for cell turnover. Let's not forget HIV, it is still very prevalent, and these children will come with very big lymph nodes as well. TB, very common, we get a lot of children here who initially start treatment as TB, and it turns out to actually be a lymphoma. Let's not forget the viruses, the EBVs, and the whole of this list of investigations, including the immunodeficiency syndromes, where you need to check the T and the B cell subsets and the immunoglobulins. We are trying to say that there are many other causes of lymphadenopathy in children, but lymphoma is one of them. When we think about doing the imaging, it's okay to start with ultrasound, simple test available everywhere in the counties, even in the health centers, ultrasound is available. You will be able to tell where the lymph nodes are and how they actually look like. CT and MRI will give more details, and for those who can access PET scan, it even gives us the metabolic activity. So the biggest question in our minds again is, when do we biopsy these lymph nodes in children? When do we suspect malignancy? If your chest X-ray is abnormal or the hemogram is abnormal, that one we do not wait. We just proceed and take a biopsy because it is highly suspicious for lymphoma. If the child is having systemic symptoms like fever, weight loss, and night sweats, and also the location, we've talked about abnormal sites of lymphadenopathy. That's a lymph node that when you see, it's okay to quickly refer, or if you're in a place you can get a biopsy, please do a biopsy so that we can catch it early and treat early. Even the character of the nodes, if they are so hard, they are non-tender, there are no other symptoms, the lymph node is bigger, like more than 2 centimeters, please let's not run around biopsying small, like 0.5 centimeter nodes in children. A child has been on antibiotics and there's no improvement, then we need to consider biopsy. Let us remember that excisional biopsy is a preferred mode to diagnose because FNS can miss the diagnostic tissue, and a study showed that it misses actually up to 30%. Let us also remember that drugs can cause lymphadenopathy. We are dwelling on this because most of the lymphomas will present as lymphadenopathy. Children on anticonvulsants, it's always good to check a drug history. Children on anti-TB, isoniazid, the aspirins, a child even who's been on tetracyclines and sulfonamides can actually have lymphadenopathy due to the drugs. And once the drugs are withdrawn for a while, then the lymphadenopathy resolves. We don't have to biopsy those ones. Malignancy-associated ones, let's remember the primary lymphomas, Hodgkin and non-Hodgkin, can also be a leukemia or metastatic lymph nodes from other solid tumors like neuroblastoma or even rhabdomyosarcoma. So now lymphoma itself is a malignancy arising from the lymphocytes, from the lymphoid tissue, can arise from B cells or T cells. And Dr. Mwendo during the leukemia talk has taken us through the tumorigenesis and how these B cells and T cells also develop. Let's remember in children, most lymphomas will be from the mature B cells, and the subdivision is either Hodgkin or non-Hodgkin. So the general classification, pediatric lymphomas, let us just remember 2 things. We just need to know, is this lymphoma originating from T cells or B cells? And is it at the immature or at the mature stage of development? So the immature lymphomas will either be T lymphoblastic, if they are from the T cell, or B lymphoblastic lymphoma. And these are patients that we have and we are treating in our wards. For the mature T, the anaplastic large cell lymphoma is a bit rare. I think we've only seen probably 2 or 3. But now this last part is the one that has the commonest, the mature B cells lymphomas, the Burkitt lymphoma, diffuse large B cell lymphoma, and the Hodgkin lymphoma. This is the commonest bulk of lymphomas that we are going to be seeing in children and we are currently treating. How to differentiate them? Morphology, phenotyping, and cytogenetic in lymphomas. This is epidemiology, and it's just to let us know that if you look at the incidence in rates per million, the top 2 is the acute leukemias and the brain tumors. Please note the lymphomas are number 3 and 4, the Hodgkin and non-Hodgkin. We are talking about between 12 to 15 rate per million. That is the global incidence. And if you look at this year data, it also shows that for all the patients under 20 years of age who were looked at, leukemias were the commonest, yes. But look at the lymphomas. After leukemias and brain tumors, number 3 was the lymphomas at 24.8%. Locally, the 2 studies that we quoted are the same studies that Dr. Mwendo has quoted. We have a study in Kenyatta, KNH here, that shows 16% being lymphomas of the patients are admitted in Kenyatta. for the last 10 years, 2009 to 2019. And in Western Kenya, for them, non-Hodgkin lymphoma was at 34%. This was a prevalence, and the Hodgkin's was at 8%. We are challenged to do more local studies, and we are on it just to see what our trends look like. So we quickly look at the non-Hodgkin lymphoma subtypes. Again, this table, the only difference is that in this table, we don't have Hodgkin lymphoma. So these are the commonest non-Hodgkin lymphoma subtypes we come across, and it reflects exactly what is in our wards at the moment. The ones listed below, the primary mediastinal B-cell, the marginal zones, and follicular ones, those ones are rare in children. They are commoner in adults. In terms of the incidence, please remember, for the younger children, it is more of non-Hodgkin lymphoma, the green. Look at the age group below 5 years, 5 to 9. By the time they get to 10 to 14 is when you are almost having 50-50, half-half, Hodgkin's versus non-Hodgkin. As they grow into teenage, now the Hodgkin's becomes more than non-Hodgkin. So the smaller babies, the little children, let us think more of the non-Hodgkin lymphoma, whose distribution is shown here. Please remember, Burkitt lymphoma is the commonest at 40%, followed by the diffuse large B-cell lymphomas, lymphoblastic lymphomas, and anaplastic large cell lymphomas at 20-20-20 each. What are the risk factors? This comes back to the tumorigenesis and to the etiology, and we've talked about, Dr. Mwendo has talked about the genetic features. But for the risk factors of non-Hodgkin lymphoma, any immunodeficiency, whether it is congenital syndromes, whether it is because of HIV or drugs that cause immunosuppression, that is a risk factor for lymphoma. EBV infection, same, is a risk factor for lymphoma and even for the post-transplant type of lymphoproliferative disease. How we diagnose, we have really insisted on that. Lymph node biopsy, excisional, with flow and cytogenetics where possible. Imaging, we've spoken about the CT scans, neck, chest, abdomen, pelvis. If you can get a PET scan, even better. Bone marrows we have to do because non-Hodgkin lymphoma will spread to the bone marrow. And we also have to do our lumbar punctures and the CSF cytology because our non-Hodgkin lymphoma in children will also spread there. We can use fluid cytology to actually diagnose. If you have a pleural effusion or an ascites, you can take some of that fluid to the lab for cytology and we'll get a diagnosis. Let us avoid steroids unless it is absolutely indicated because it poses a diagnostic challenge. This slide just shows us some of the features of Burkitt lymphoma, commoner in males 5 to 10 years. This is the immunophenotype for Burkitt lymphoma, CD10, 19, 20, 22, with the surface immunoglobulin and low BCL2. In terms of cytogenetics, these are the translocations that you will find involving the heavy chains and even the light chains, the kappa and the lambda chains. If you're able to get these tests, then you get your confirmatory diagnosis. And the Ki-67 will be very high because it's a very proliferative disease. Let us also remember the sporadic versus endemic. This has been an old classification that still exists. In our area, Equatorial Africa, more of the endemic, whereby it was a classical jaw mass. Nowadays, we are seeing a lot of the abdominal mass. So this is not absolute. We are actually having more children with abdominal Burkitt's now in the wards in the Kenyatta than the jaw masses. And let us also remember that there's a difference in where the breakpoint at chromosome 8 is. For sporadic, it's within the cymic, but for the endemic, it's upstream of the cymic. How do they present? All those masses, jaw, abdominal, the lymph nodes, orbits, can even be in the spine. Small bowel obstruction with intussusception is a classical feature. When you hear a child went to theater for intussusception or had small bowel obstruction, we must have a very high index of suspicion that that could be Burkitt lymphoma, could be abdominal perforation, CNS signs, all the features of bone marrow dysfunction that the leukemia talk has given, all those anemias and bleeding and fevers, tumor lysis or even paralysis. Now, please let's remember the oncologic emergencies. And we thought of just putting it as A, B, C, D, E, F. Because children with lymphoma can present with airway obstruction, compression, because of the superior mediastinal syndrome. The B is breathing, they come with effusions in the lungs, circulation, superior vena cava syndrome. They can come with cord compression and paralysis as the D for disability, electrolyte imbalances because of tumor lysis, failing organs, especially the kidney. The GIT is very classical for children. GIT obstruction, intersusception, even perforation in the GI and bleeding is suspicious for lymphoma, bucket especially, and the hematologic manifestations. This is the pathology, the classical starry sky appearance that they always taught us about. It has not changed. And when you see this one, we are thinking buckets, and we've talked about the stains that you look for immunophenotype and what we are actually going to see. And that the Ki-67 will also be really, really high because of the proliferation. This is how we stage. Murphy staging, it's also called St. Jude. Every time we see a child with cancer, we have to ask ourselves, what is the stage? Because the earlier the stage, the earlier the chances, the higher the chances of cure. Let us just remember the demarcation is a diaphragm, and that stage 1 is a single site or extranodal tumor, but excluding the mediastinum and the abdomen. Stage 2, you will have either in the lymph node or a site out of the lymph node, but they are both on the same side of the diaphragm. Also, if the GIT tumor is totally resected, it still becomes a stage 2. Stage 3 will be involved in both sides of the diaphragm, but let's also remember that any disease in the lungs or the pleura or a mediastinal mass, that one goes straight to stage 3. Even any primary intra-abdominal disease, abdomen stage 3, and even paraspinal is stage 3. Stage 4 bone marrow or CNS. We also risk stratify, same concept that has been presented with the leukemias, group A, B, and C, with A being low risk and C being high risk. Please, we just have to know the group A, stage 1 and resected stage 2, and then we know the high risk, CNS disease and bone marrow involvement. Everyone else, every other child will be group B, which is the intermediate risk. So once you can exclude group A and group C, every other child will be group B, and you can be able to put them in the correct risk stratum for their treatment. Principles of therapy. So it is risk-based treatment because we are using multimodal chemotherapies, and for the lymphoma, especially buckets, it's the intensity of the treatment that matters. And we are still taking this chance to really welcome you to come and join us at the Pediatric Oncology Workshop on 20th and 21st of September, 2 days. We shall be going into all these details, just talking about childhood cancer, and we shall go to all these regimens, the protocols. What are we able to support in our setting? What can we give? And what outcomes have been shown to be attached to each regimen? And the link for that workshop is being pinned in this particular forum. If you're interested, you can register. Radiotherapy is only useful if you have CNS parenchymal disease. Surgery has a small role, especially in the low stage resectable disease, the one you are putting at stage 1 or stage 2. Intrathecal chemo is a principle of therapy for all of them. Whether they are CNS positive or negative, they have to get CNS prophylaxis or CNS treatments. Let us also remember another principle of therapy will be a preface for group B and C disease. Please, let's always look out for the oncologic emergencies in these children with lymphoma as we manage them. Prognosis is good, more than 90%. In the centers that can offer the standard of care. And this means optimal doses. If you're giving methotrexate, you're talking about huge doses, like 8 grams per meter squared. And you'll find in our setting, most of us, the supportive care we have and the resources we have, we are not able to offer the standard of care and the optimal doses, but we are making positive steps towards there. We want to get those 90% cure rates that are in the West. Worst prognosis is if there is CNS or marrow involvement. Please remember for buckets, once they relapse or if it is progressive, salvage is highly ineffective. So the survival becomes very poor, and we are talking about 30% even in the best of centers, even in the world, with extremely intensive chemo and even stem cell transplants. Still, we are not able to salvage these children. The other common one is diffuse large B-cell lymphoma. Remember, this one presents with lymph nodes all over the body, as opposed to the bulky masses we see with buckets. Often in immunodeficient children, let's remember it's similar to buckets in many ways. The ones that are BCL6 positive will have a good prognosis, and they have a lesser risk of CNS disease. These children, we treat them exactly the same way that we treat the Burkitt's lymphoma in children. The anaplastic large cell lymphoma, also a non-Hodgkin lymphoma in children, this one is clinically aggressive and extranodal, most of them about 60%. For these ones, CNS disease is not common, but they have systemic symptoms in very many of them, like 75%. They tend to be advanced stage, and their hallmark cell is a horseshoe-shaped cell, which our pathologists are usually able to see and describe very well when making the diagnosis. They tend to be CD30 and ALK positive, that is the anaplastic lymphoma kinase positive with this translocation 2-5. So where we are able to do cytogenetics, let us not spare any resources in trying to confirm this diagnosis and to treat, because this is a targetable tumor. They also get a preface and they get the standard protocol chemo, where we shall go through all the drugs and the agents and how they are administered during our pediatric oncology workshop on 20th and 21st of September. Relapse rates are high, but the survival is actually excellent. And these ones are very salvageable. We just said Burkitt's, when they relapse, it's a bad story. But for these ones, you can salvage. They can also get a targeted therapy, anti-CD30, a monoclonal antibody, brentuximab, and they can also get crizotinib, which targets that anaplastic lymphoma kinase, and they truly respond. Now, lymphoblastic lymphomas, another very common non-Hodgkin lymphoma, where the T cell is more than the B cell. 90% of the LBLs are T cell, and they tend to present with a mediastinal mass, stage 3 or 4 disease. And we went through the immunophenotyping and the markers that you shall see on flow cytometry and IHC to be able to differentiate the two so that we treat the exact accurate diagnosis. And these ones are treated the same way the acute lymphoblastic leukemias are treated. These images just show us a mediastinal mass. Please, if you ever come across a chest X-ray looking like this, or a CT of the chest with this mediastinal mass, just recognize this emergency, suspect lymphoblastic lymphoma or leukemia immediately, and then please send. Feel free to refer the patient at any point. Now, Hodgkin's, all that was non-Hodgkin's. You're looking at this nice owl, you can see those eyes, and you can see this classical Reed-Sternberg cell with the owl's eye, and the owl just put next to it. That is Hodgkin lymphoma, one of the most common cancers between 15 to 19 years, very common there, but still makes 6% of pediatric cancers in the other lower age groups. Please let's remember that this one can be familial in 5% of cases. If you have an identical twin, monozygotic twin, you have a 99-fold risk of getting Hodgkin lymphoma if your other identical twin has it. So we counsel families, even if there was a sibling or a parent who had Hodgkin's, this can be a familial disease in 5%. It is also associated with all these immune dysregulation conditions, including EBV infections and all these immunodeficiency syndromes, including HIV and the ones who are taking immunosuppressive drugs. Hodgkin's lymphoma has 2 subtypes. The classical Hodgkin's that we all know, which has the 4 subtypes: nodular sclerosing, mixed cellularity, lymphocyte predominant, and lymphocyte depleted. Then it also has the rare type, the nodular lymphocyte predominant type, in about 10%. This is how these children present. And we see a lot of babies out there running around with swollen big lymph nodes on the neck. Please let's take initiative as we raise awareness to just ask them to come and get checked. You can see the lymph nodes in this child, so lymphadenopathy in 80%, no pain. The children are usually having no pain, but they can also come with airway obstruction, and the disease can involve the spleen, liver, lungs, bone, and bone marrow. Systemic symptoms, very important, the B symptoms. Please, if the child has fever, and the criteria is clear, unexplained fever more than 38, 3 consecutive days. Unexplained weight loss of 10% or more within the last 6 months preceding, and the drenching night sweat. This is very characteristic of the B symptoms of Hodgkin lymphoma. The diagnosis is by histology. This is a classical Reed-Sternberg cell. We also saw it at the beginning of the presentation with this inflammatory infiltrate around it. So once you have that histology, you go ahead and do the immunohistochemistry. And here we are looking for CD15, CD30, CD45, PAX5, and EBV. And just note the difference between the classical type and the nodular lymphocyte predominant type. They are just direct opposites. The first one is CD15 positive, 30 positive, 45 negative. The other one is the opposite. CD15 negative, CD30 negative, CD45 positive. This is how we stage. Every time you see a lymphoma in a child, we must stage and risk stratify. This is the Ann-Arbor staging. Again, the landmark you use is the diaphragm. So it is either stage 1 and 2. We are above the diaphragm, depending on whether it's a single region or 2 or more regions involved. Stage 3, we are involved in both sides of the diaphragm, including things like the spleen, and whether it is an extra lymphatic organ. Stage 4 is diffuse or disseminated disease to other sites. Please take note of the substage classifications. They are important because B symptoms are prognostic. So A is asymptomatic, B is when you have B symptoms, E stands for if there is extra lymphatic organ involved, S is for the spleen, and X is for bulky disease. And again, the bulky disease is also very clearly described. You'll be able to see it on your imaging. If the tumor is more than a third of the thoracic diameter, even on your chest X-ray, you know this is bulky disease. If this lymph node aggregate on the neck is more than 6 centimeters, that is bulky disease, and this affects the prognosis. And also if you have macroscopic splenic nodules. Among the tests we are going to do, if you can access PET scan, it's highly recommended because it will show us the metabolic activity. But CT scans is okay, neck, chest, abdomen, and pelvis. We need to do the echoes and the ECGs because of the medicines we are giving can be toxic to the heart, and even the pulmonary function test because of bleomycin, toxicity also to the lungs. For Hodgkin, we need the bilateral bone marrow aspirate and biopsies, especially for stage 3 and 4, or a patient with these symptoms. PET can actually pick bone marrow involvement. Let us offer them the fertility counseling. And remember, we don't need to do a lumbar puncture. So we don't do CSF analysis for Hodgkin lymphoma as opposed to non-Hodgkin lymphoma. This is how we risk stratify our Hodgkin lymphoma because the treatment is risk-based. Again, we just need to remember what is low risk and what is high risk, because everyone else will fall in the middle and they'll get the treatments for intermediate risk. High risk is any stage 3B and above is high risk. Low risk is only stage 1 and stage 2A, so long as there is no bulky disease. Every other category of the child with Hodgkin lymphoma will fall under intermediate risk. What are the principles of therapy? So we are saying principles because we are not able to discuss the details of the treatment in this meeting. It is multimodal chemotherapy for all the children, and it is risk adapted. It is based on how severe is the disease and an objective response to therapy. This means from the beginning, you've done all these scans and quantify. We must measure the extent of the disease, real measurements, so that after 2 cycles, you can be able to measure again and compare and tell, after this chemo, is this a slow early responder or a rapid early responder? And which part of treatment do they take after that? So it is risk-adapted therapy. The regimens are many, and we shall be able to discuss them in detail at the workshop. Radiotherapy, very important in Hodgkin lymphoma, especially for high-risk disease, stage 3B and 4B. And also for the slow early responders, any bulky disease and those with residual disease. Prognosis is very good with an overall survival of more than 90%. These are the different ways the radiation is given for patients with Hodgkin lymphoma, whether it is mantle or whether it is involved field or involved node. The idea is to try and just minimize the surface area that you are exposing to radiation because of the side effects. These late effects, because our children with Hodgkin's are surviving for a long time. We have many survivors. We have to be on the lookout for these late effects, which Dr. Mwendo has also gone through them very well in the leukemia section. So I will skip that. And just finally talk about the nodular lymphocyte predominant Hodgkin lymphoma. This is a rarer type of Hodgkin lymphoma now, but this one has good prognosis. Commoner in boys. Usually it is localized. It's a nice thing because it is localized. It doesn't have bulky disease. They don't have B symptoms. They are often EBV negative. So this is not a very bad type to have. Stage 1A may only need surgical resection and they are cured. we treat them the same way, like the classical Hodgkin lymphoma, but let us remember about 10 to 15% may transform to diffuse large B-cell lymphoma. So in summary, for the childhood lymphomas, for non-Hodgkin's lymphoma, they generally have a favorable prognosis if we are able to deliver standard of care treatment at optimal doses. And it is generally chemotherapy-based, so surgery and radiotherapy may not have much of a role. For Hodgkin's, any child with painless lymphadenopathy, at least the take-home message is all these children with big lymph nodes, painless running around, please, we need to biopsy them to rule out Hodgkin lymphoma, excision or biopsy. And let's remember, Hodgkin has a very good prognosis, even if they are stage 4 or even if they relapse. Hodgkin's, they are salvageable. And there are many exciting options in the future. We are thinking about how to minimize toxicities and late effects because our children are surviving longer. And so those were my references, and thank you very much. We'll be happy to take questions and comments. Thank you.
Thank you very much, Dr. Nzamu. And also thank you again, Dr. Mwendo. I'm looking at the chat and everyone is excited about the presentations. Everyone is saying it was very informative. It was well-timed, it's clear, it's concise. So and people are generally happy that they've attended the webinar. So thank you again for the presentations. They were very well done. They were very concise, they were very informative. And I believe as healthcare workers, we have all gained some knowledge, we've all learned something new. And we've actually made a step forward when we are in terms of discussion about pediatric hematology and oncology. And I'm sure as we go back to our areas of work, we'll be much more keen in terms, we'll be more keen in terms of looking out for all these features of leukemias and lymphomas, and we'll be able to do the right thing once we see. So we'll go straight to the question and answer. I'll start with this one. Someone is giving a particular case. He's saying a child has complained of a leg pain and headache almost daily, and a full hemogram was done. Everything was okay except HB was 11, and the child was given ranferon and is okay. So the person is asking, do we need further diagnosis for this child, or do we need to do further workup? Dr. Mwendo, you can take that up.
Okay, thank you for that question. So for this child, 3 weeks is quite a long time to be having headache and leg pain. However, we still need more history from that. And even the examination is important because a lot of things are coming to my mind. Could it be an infection? Could it be traumatic? So some history and examination are needed. However, he goes on to talk about a blood count that seemed normal except an anemia that seems to be improving with ranferon, and the child is okay. So, I mean, I don't know if what it means by the child is okay, like the headaches have resolved, the leg pains have resolved, or what does that really mean? However, if the symptoms persist, then we need to go ahead and work up this child. If the blood counts are abnormal in this situation, there's anemia, at least we can start off with a peripheral blood film. A peripheral blood film will give us the morphology of the blood cells, the 3 cell lines, the white blood cells, the red blood cells, and the platelets. And then we can take it off from there in terms of screening for leukemia. Thank you.
Thank you, Dr. Mwendo, for that one. I think we are reminded that on our pediatric hematology oncology workshop, 28th and 21st of September, so the registration link has been posted on the chat box. So kindly see that link, click on it, then register for the workshop. So we'll go to the next question from Wamae. He's asking, how are the diseases vital indicators in Kenya compared with the regional and global outlook? And what are the drawbacks, if any? Okay, can't understand that question. I don't know if anyone can understand what exactly they asked, or if we need to ask him to speak and clarify that question. Anyone understands?
I think he can.
I think he can clarify, although I'm thinking he's asking where we are relative to the rest of the world.
Yeah.
Maybe in general, we could just say we are still far behind compared to the rest of the world in terms of outcomes. And the reasons is really what Dr. Mwendo gave, the treatment abandonment, you know, the lack of resources, the supportive care that we need to be able to give the optimal doses and optimal treatments needed for these children. But if we can clarify further, I think we'll be able to answer better. Thank you.
Okay, so once I get to the place where people will raise up their hands, I'll ask him to clarify if the question hasn't been answered. But we'll go on with the questions on the chat box. Hilary asks, okay, they say it's a very informative presentation. So they ask comment on the cost and availability of the services and how we can enhance diagnosis. So any can take up that, that query. Dr. Mwendo, comment on cost and availability of services and how we can enhance diagnosis.
Okay, thank you, Dr. Wata. So I believe you're asking about the cost and availability of these services in Kenyatta National Hospital, or
Yes.
is it generally in the country?
Yeah, we can talk about, let's just talk about generally in the country, yes.
Yes. So as far as I'm concerned, cancer treatment is being offered in various facilities, in the private facilities for sure. But when we look at the public facilities in Nairobi, it's being offered at Kenyatta National Hospital. In the western parts of the Kenya, it's being offered at Moi Teaching and Referral Hospital. And even at Kisii, Teaching and Referral Hospital, and in the coastal area, it's been offered at the Coast General. There are also other facilities that I won't mention that also partner with us. They could have availability of the resources, but we tend to collaborate together and treat the children. But those are the major hospitals that they are offering these services. In terms of the cost, we have, Kenya has the national, the NHIF. And so if the family has an NHIF, they paid up their NHIF, then the cost is essentially free. But there is a caveat because I think there are limits to that, but essentially it is free. When it comes to if they don't have the NHIF, then I might not give the specifics in terms of the costing of A, B, C, D, but we all know that cancer care is quite expensive, and it could be very pricey. But with insurance, then it becomes free. Availability of services, most of the resources we have at Kenyatta National Hospital. There are some diagnostic challenges we might be having, for example, immunophenotyping by flow, or even immunohistochemistry. And I'd like to say that we've partnered with, we're sort of having a collaboration with Aga Khan Hospital, where they subsidize the costs for the patients who are referred from Kenyatta National Hospital. There's also some grants that that are available when need be, and so we also collaborate with Gertrude's Children's Hospital for some of the tests that they're not available at Kenyatta, and then they are actually done sometimes at no cost to the patient. Rarely, we might have some drug stockouts, but this is quite rare. We seem to have most of the drugs available at Kenyatta National Hospital. Maybe I will ask Dr. Wata, who is our clinical pharmacist, to comment on the drug availability. Thank you.
Okay, yes, thank you, Dr. Mwendo. Being a public hospital, sometimes we have issues with the medicine availability, but we try and work with the system to ensure that all the medicines are available. Remember, Kenya has some certain legal provisions and laws which in some cases may actually hinder access to medicines. But it means here for us, we just have to work much harder for us to be able to make the medicines available. Again, also, supply of medicines is actually a business. And therefore, those that do that business normally have to try and see some economic sense and economic value. And sometimes for them, they feel for some things they may not make some economic sense. And therefore, you have low investment in some particular types of medicines. And therefore, in such cases, you have a few challenges. But we are trying to work with the system to ensure that these are resolved. We're also trying to work with some external organizations to try and mitigate some of these challenges in terms of medicine stockouts. Yes, that was what I wanted to add. So we'll go to the next question. Kezia is asking, is ATG treatment a treatment option for pediatrics? So ATG antithymocyte globulin. So I think I'll just answer that one. That one would mostly be used for aplastic anemia, but not for acute leukemias or lymphomas. But it will be used in some cases of aplastic anemias. Going through the chat box, so it's there's still more congratulatory messages. Then Winnie asks, what is the role of craniospinal radiation in leukemia? So Dr. Nzamu, would you take up that question?
Dr. Wata, which question again?
What is the role of craniospinal radiation in leukemia?
Yes. Yes, craniospinal radiation has a role in acute leukemia, especially for the children who are CNS positive. So part of the risk stratification criteria we use in the children is presence of CNS disease. And if you have CNS disease, then you're high risk. And CNS disease can mean the fluid that came from the back, the CSF is either positive, or it can also mean you have a cranial nerve palsy. So you find a child with a dysfunction in one of the cranial nerves, or it can even mean that the child has an intracranial lesion. Part of the leukemia cells or part of the tumor have formed a deposit in the brain. So any of these categories of children with CNS disease with leukemia are candidates for craniospinal irradiation, and it is available and it is offered even here at Kenyatta National Hospital. Thank you.
Thanks, Dr. Nzamu. So the next question by Odongo is, can the presenter make a mention of CAR T-cell therapy in ALL?
Okay. Thank you for that question. So basically, when we talk about CAR T cells, this is falls under the category of immunotherapies. So it's a new and promising technology for the treatment of B-cell ALL, B-cell ALL. So CAR T-cell just means it's a chimeric antigen receptor T-cell. So you have a T-cell that is engineered to sort of like express artificial receptors that would specifically target an antigen on the surface of the cancer cell. What do we know about B-cell ALL? They express CD19. CD19 is a cell surface protein that is expressed on B cells. And the B-cell leukemia cells would express then the CD19. So they are CD19 positive. So these CAR T cells would be engineered in a way that they have receptors that bind to a specific antigen. So in this case, it would bind to CD19 on the cancer cell. And thus, so now the T cell then goes ahead and destroys the cancer cell. So it's a promising immunotherapy that is used in B-cell ALL. It is still ongoing trials. It has most of the trials have been used used in adults. However, there are children trials that are ongoing, and they are promising because they're talking about the children who have had an opportunity to be treated with the CAR T cells. Their complete remission rate is about 83%. Yes. Another promising immunotherapy for B-cell ALL is something called blinatumomab. It's a BiTE cell. Again, just using the principles of, it's a T cell that has two receptors. One has CD3 and the other has CD19. So the CD3 will bind to a T cell, and the CD19 will bind to the cancer cell, the B cell leukemia. So it sort of like brings them together so that destruction can happen. So that's a bispecific T cell engager. So it's called a BiTE cell. So those are the two immunotherapies that have been approved for use in children with leukemia. Yeah, and they are also an example. Those are examples of targeted therapy, because you're targeting a certain protein or a certain characteristic in that cancer and programming it for destruction. Thank you.
Thank you, Dr. Mwendo, for that. Yes, those are the two immunotherapies that are currently available, though we don't have them locally. As it is in Europe and in US where they're used, they are very expensive. And so we'll have to wait until a time when they'll be accessible to our economic levels here in Kenya. The next question is from Josephine Wanjiru. So Josephine asks, in patients with the thrombocytopenia, at what platelet count is a BMA an absolute contraindication? So Dr. Nzamu, you could take that question.
Yes, Dr. Wata. So in patients with thrombocytopenia, and especially if they are bleeding, so we'll offer them the supportive care by way of platelet transfusions. But the truth of the matter is that thrombocytopenia is not a contraindication to doing bone marrow examination. If we need the bone marrow to make a diagnosis, so we'll be able to safely do that bone marrow with our hematopathologist in attendance, and we'll be able to support the child with platelet transfusions. As soon as we have a diagnosis, as soon as we start the treatment and the chemotherapy, the thrombocytopenia will recover. So there is no figure of platelets that is a contraindication to bone marrow examination. Thank you.
Thanks, Dr. Nzamu. I think most of the messages here are people are saying are complimentary messages. People are really excited about the presentation you guys have made, and I think you've made a really great impact on those that have attended this CPD session. For the admin, kindly note those that are asking for the presentations, those who really enjoyed and they would like to read further, so they would like that these presentations. So if it's possible to make them available, kindly note their email so that they can be made available. As I cannot seem to see any other question here, probably I can just as a question for as we try and wind up, because we are talking about children, and we know many of our children at the age when they are diagnosed, they are going to school, they have all these other issues, and as we've talked about, patients have to be admitted, some have to go for therapy for at least 2 years. So what are some of the things we can do to support the children, to support the families, to enable these children at least live a full life, at least enjoy life as much as possible, even in spite of the diagnosis that they have? And I'd like to welcome everyone in the panel to answer the questions. I've seen Dr. Muma, I've even seen Dr. Zipporah Ali. So kindly just chime in and give in your comments on how we can support these children and how we can support these families to live full lives, even in spite of the diagnosis that they have. We can start with you, Dr. Mwendo.
Okay, thank you very much, Dr. Wata. So during my fellowship, what message I learned the most in my experience is having cancer is not the end of life. It's not basically the end. So that's why even in Kenyatta National Hospital, you find that even within our floors, these children have access to almost like a formative education. There is a classroom where they go, they interact with other children, where they go and learn, they go and interact with other children, just almost like living a normal life. So the first part of their journey is to attain a diagnosis. And once you attain a diagnosis, then it is a multidisciplinary effort to actually try and give this child the best treatment possible. And it can't be communication amongst the healthcare workers without involving the families. So partnership is important, whereby the healthcare providers and the families, they come together and discuss about the child, such that you're involving them in every step of the way, and they really, really, really appreciate that. They want to know what's going on. They want to know the progress, whether it is good or bad news. What I've seen that is important is communication. So communication is key. For the children who are much older, also having a discussion with them is also important. Don't keep these children in the dark. You give them information up to their level, what they can be able to understand. Because if you don't, then they have their own myths of what's going on, and they can be thinking, I'm dying tomorrow, I'm going to die anyway. Okay, so part of the multidisciplinary effort has to involve everybody, including counseling. The counselors, they really do a good job in Kenyatta to just give that correct information we give the parents all the time they need to digest and understand what's happening. So communication for me, I think, is the first point. Second point is we just treat these children humanely and just as how they would be treated elsewhere, not like very special, as if they are very friable, like they're fragile. So I think also our verbal and non-verbal communication needs to almost be sort of saying the same thing. Okay, so I think I will leave it at that for my part, and we can have others talk about what else we could do.
Thank you, Dr. Mwendo, for that. Dr. Irene Zamu?
Yes, I totally agree with Dr. Mwendo. And what I would add is to say that in Kenyatta National Hospital, now we've been able to operationalize the daycare chemotherapy for children. And this really allows them to live their life, because previously, and for most of us who trained in Kenyatta National Hospital, you know, the children never used to go home. And so it's like the life comes to a standstill with a diagnosis of cancer. And you have to stay for months and months and months in hospital. Over time, the approach has changed. And now children are able to actually just be children. Let's allow them to live their life. When they are receiving chemotherapy that is not very intense, they're able to come in the morning, have their blood test done, receive their treatment, and go home. And we are able to continue following them in clinic and monitoring. This has allowed them to pursue their hobbies. Those who are able to go to school can go to school if the clinical condition allows. It also gives them time with their families and friends to be able to live an almost normal life. So we would encourage as much as possible that the children at home are able to interact with their family and their peers. And we only need to admit children in the hospital for the intense chemotherapies when they are sick, so that they can also have some balance of like normal life as we support them to just grow up and be children like any other, despite a cancer diagnosis. Thank you.
Thank you, Dr. Nzamu. Something to add, Dr. Sarah Muma. Dr. Sarah Muma is one of our pediatric oncologists here at KNH. Dr. Muma, are you there?
Yes, thank you, Dr. Wata. Yes, I'd also like to add what helps also with the treatment is, and some of the things we are already doing, we do have support in terms of play therapy, so, and continuing education, even while the children are admitted. So we have volunteers who come in and also ensure the children are still learning, because some of them are already in school and may have had interruption of their school. Also, play therapy keeps them distracted, so that even if they are continuing with treatment, then they are stimulated, they are happy, and they can continue with their lives as children. So I would add that just trying to ensure that their lives continue and have not stopped just because of this treatment, which is for a long duration.
Okay, thanks, Dr. Sarah. Dr. Makori, I've seen you there. Would you like to add something? Dr. Makori is one of our hematologists here in KNH.
Thank you, Dr. Wata. Hello, everyone. Thank you for this enlightening presentation. I enjoyed that they were precise, concise, and also straight to the point and very clear. I hope that now we understand the importance of at least minimal investigation, even when you are suspecting a patient could be having some hematological problem, before even you rush to transfusion. I understand that transfusion is an emergency, but by the time you are going to the second transfusion, let's have some minimal investigation in form of hemogram, full hemogram, peripheral blood film. And if they are not available in your setup, if you are at the periphery, at least insist in your hospital to have somebody looking at the peripheral blood film. That will really help, because we are getting patients who have been transfused up to 4 times and nobody has ever looked at the peripheral blood film. And with each transfusion, you are changing now the markers of the disease. Sometimes they go into partial remission and you delay the diagnosis that way. And we may lose the patient before you get a diagnosis. So that would be my take. Otherwise, thank you very much for this presentation.
Thank you very much, Dr. Makori. I've seen Dr. Zipporah Ali is also here in this meeting. Dr. Zipporah Ali has vast experience in palliative care. She was the Executive Director of Kenya Hospice and Palliative Care Association, and also the boss at Nairobi Hospice. And she can tell us a few things about supportive care for children who've had a disease diagnosis, how they can live a full life. Dr. Ali.
Okay, you ambushed me. I was just a participant. But yeah, thank you for the presenters. I think they've done a great job. And I think the other three people have just responded. I've actually talked about supporting children with a cancer diagnosis. I think one of the most important things that has come out is that we have to remember their children always. They are not little adults, they're children. And hence we should actually treat them as such. And I remember when I started working in KNH in the late 80s, the pediatric oncology ward was very depressing for me because kids were just there for treatment. And like somebody said, they stayed for a very long time. There was nothing for these children to even just interact in a normal life, understand what's going on. And I'm glad that over time things changed and they introduced even schooling within the oncology, pediatric oncology ward. They allowed volunteers to come and spend time with the kids, read books for them. So I think this kind of support is very important for a child. But one of the things I would find when I went to the oncology ward, I'd ask the child what they would like, and they would simply sometimes say, I just want to go and spend Christmas with my family. And if a child is in hospital and it's Christmas and they're not undergoing any active treatment at that time, why not take this child home to spend time with their family? And Hope for Cancer Kid even came up with a program at one time when we would have one day in a month and bring the parents of these children to KNH to have just a social day in one of the grounds in the field. So these things are very important for children. Visitors, of course, screened so that they don't bring infections, but also just schooling, reading books, playing with other children, but also information from their family is very important. They want to know what's happening with the other siblings, and then talking to the other siblings, because sometimes the child who is sick is the one who gets all the attention in the home and the other children are ignored. So again, engaging those other children in taking care of this other child might actually make them understand what's going on. And one of the things that I found that was very difficult in KNH is when a child passed on, there was no, at that point of time, those years, there was nobody counseling the children in the ward that had witnessed their friend die. So I think even as we're talking about treating children, we need to look at even the children who are friends of this child who might die. How do we support them in bereavement? How do we help them grieve? And so I think most of the things have been spoken about, but family support is also very important. Remember, a sick child is a devastated family. The parents are completely devastated. The siblings are devastated. The child does not understand what's going on. So we need to support the family as well. And during treatment, we should try to minimize the side effects of the medication so that this child is not continuously sick, that can still continue living as much as possible a normal life. So I think everything has been said. I just want to add that children are children, and we should never forget that. And children also benefit from palliative care. One of the things we see in this country is that children are not actually referred for palliative care. We get about 99% adults patients, but very little amount of children. But we know the children are there, they're sick. Referring a child for palliative care doesn't mean you have given up on the child. It doesn't mean that you have decided the child is going to die. They will need this support, emotional, psychosocial, spiritual, symptom management, especially pain, supportive care for to be able to manage the side effects of their treatment. And this is where the palliative care teams come in, because as the first speaker said, they said that we want to aim at 90% cure like the Western countries. So if you're going to even attain this cure, we have to minimize all those other things that make the child not tolerate the treatment. So again, a lot of things that we can learn. And I'd like to support you that children do deserve palliative care. It improves their quality of life. It even prolongs the survival rate. It reduces on many things like hospital cost, and even the patient's cost, because they're coming for symptom management every now and then to the hospital. So thank you very much for the very engaging session. Thank you very much.
Thank you very much, Dr. Ali. Sorry for ambushing you, but as you know, since I saw you here, with your vast years of experience and your expertise, there was no way I could leave you without speaking. So thank you for giving your comments. So I'd like once again to thank our speakers, Dr. Irene Zamu, Dr. Kathy Mwendo. Thank you very much. There were so many congratulatory messages for you. People are very excited to have heard your lectures, and people have gained a lot of knowledge. So we thank you very much. And I think we should keep that fire so that more and more people are learning about pediatric oncologies. And I think that way it will help us in early detection and early diagnosis of pediatric oncology and hematology cases. So with that, I think we've come to the end of our session. We've come to the end of our CPD. And so at this time, I'd like to hand over the floor to the admin so that he can address some of the CPD issues which I've seen very many people lamenting about. Thank you.
Thank you once again, Dr. Wata, and the rest of the team, Dr. Irene Zamu and Mwendo. On addressing the CPD points, we shall go via CADA. For the nurses, you will be receiving your CPD points via email in the course of today or tomorrow. For the clinicians or clinical officers, the attendance sheet for this session will be sent to the COC, and they will award the points through the portal. So you can always be checking on your account to see the status of your points. For the PPB, there was an issue last week for the CPDs that was sent, but it has since been sorted out. So you should just visit the portal and subscribe to the events that you did attend. The previous events from last week and this week will be updated within the course of this week. So be sure to subscribe to those as well, and also be on the lookout for the upcoming events. If you have any complaint or any issue to do with CPD points, kindly email KNH-UoN@gmail.com, listing the events that you haven't received CPDs on, or the events that your CPDs have issues, and we'll be able to sort you out through that end. Thank you once again for attending this webinar. Do have a wonderful afternoon.
Thank you. Have a good afternoon.